Hello everyone, I'm Salwa Zghebi from the Centre of Primary Care at the University of Manchester. I'll be presenting our study around assessing the severity of cardiovascular disease in people with coronary heart disease using primary care data in England. Coronary heart disease is the most common CVD and it's the leading cause of deaths globally, where in 2016 it was estimated that it was responsible for nearly 10 million deaths. In the UK, its prevalence is nearly at 3%, where it's estimated that nearly 2.3 million people have coronary heart disease in the country. The majority of current stratification tools, they are available, but they are for people without CVD and with very few tools available in clinical practice designed for people with prevalent cardiovascular disease. In this study, we aim to develop cardiovascular severity scores in people with coronary heart disease by using routinely collected electronic health records for primary care in England. We also aim to evaluate the association of this score with the risks of all-cause and cause-specific hospitalization and mortality outcomes. We included data from the Clinical Practice Research Datalink with access to linkages to the ONS, Office for National Statistics, for cause-specific mortality data, hospitalization data, and social deprivation as recorded as index for multiple deprivation. We included people who were diagnosed with coronary heart disease between 2007 and 2017, who were aged 35 years or older, registered in English general practices. We then divided the cohort into training and validation data sets. For each patient, we calculated baseline and longitudinal scores based on severity domains, and the longitudinal scores were up to 10 years after index date, which is the earliest coronary heart disease diagnosis date. Covariates included age, gender, ethnicity, and the patient level IMD. We fitted Cox regression models and competing risk regressions, where we used to evaluate the association between severity and the primary outcome, which was 1 year all-cause mortality. Secondary outcomes included 1 year cardiovascular or diabetes-related mortality, 1 year any cause hospitalization, or 1 year cardiovascular and diabetes-related hospitalization. We also organized a half-day PPI event where we invited people with coronary heart disease to get their perceptions around the severity domains and what they think they are severity indicators for their condition. In total, 213,088 people with coronary heart disease were included in the analysis. 23% of the patients died and 81% had at least one hospitalization during follow-up. In the fully adjusted model, we found that for each 1 unit increase in the baseline score, it was associated with increased risks for all-cause mortality by 41%, cardiovascular or diabetes-related mortality by 59%, any cause hospitalization by 27%, and cardiovascular or diabetes-related admission by 37%. The predictive value of the models was overall very good, ranging between 0.8 and 0.9. The PPI participants' perceptions of the severity domains varied overall. We received very positive feedback around the event, and they all agreed on the importance to assess the severity of coronary heart disease. And some of them stated that they found it useful in terms of improving their knowledge around the coronary heart disease severity. The adjusted Kaplan-Meier survival plots show clearly the worst survival outcomes associated with high severity at baseline, as represented by the dashed orange line, in comparison to people with no severity as assessed as a severity score of 0, as represented by the solid blue line. In summary, we found that a higher cardiovascular severity score in people with coronary heart disease is associated with increased risks for hospital admissions and mortality. This tool is based on routinely collected data and provides a reproducible algorithm that can be used to assess the severity of other chronic conditions managed in primary care setting. This tool can support practitioners to provide more individualized patient care and can have wider implications on the individual patient and population health care. Our research team included collaborators from 6 universities. Thank you for listening, and please add any comments in the feedback section.